This is nursing care of the child with an alteration in bowel elimination or a gastrointestinal disorder, Part 1. So physiologically, the differences between children and adults in an infant, that's where, or young child too, that's where they get infection, right? Everything goes into the mouth. So things that are dirty and full of germs go into the mouth and they get sick. The esophagus, the lower esophageal sphincter on a neonate is very loose. It doesn't have its tone yet, which is why babies spit up. Some that tone will come by about a month, but some it doesn't come till they're more like a year old. And that's why we see so much regurgitation or reflux. Stomach capacity, a neonate holds very little. 10 mLs may be all they get, all they can hold in their stomach. Feed them more than that and they spit up. They also have very little acid production in their stomach at birth, and that's good. Since they are spitting up, it's not acidic, so it doesn't do that damage, that erosion of the esophagus. Intestines, the small intestine is not very mature at birth, which is why they can't tolerate other foods. They're really, breast milk is the best and formula is the next best. If you've had a toddler and you've given them things like raisins, well, they just plump as they go through, but they come out exactly the fully, little raisins, because their intestines just are not mature. Biliary system, relatively large at birth, but the pancreatic enzymes are not equivalent to adult levels until they're about 2 years of age, which again goes with that breaking down of foods. They can't break down fats and proteins and complex carbohydrates. They just don't have the pancreatic enzymes to do that. And then fluid balance and losses. An infant has proportionately more body water than an older child, and a child has more body water percent of their body than an adult. That makes for fluid shifting much more easily, which makes them prone to dehydration. It also allows for more insensible losses. So when a child has a fever, their need for fluid goes up. So when you do an assessment on a child, we do want to get their health history because we're looking at growth. Have they always been at the 5th percentile? And is their family all 5th percentile? Well, then it's normal for them. If they were at the 80th or 90th percentile and they've dropped down to the 5th and they come from a really big, tall family, now we have an issue. And also, is there a family history of GI illnesses? Many of these do have family tendencies. We're going to look at their color. Are they pale or are they jaundice, which, is the yellow? Their hydration status. Looking at the oral mucosa. Turgor, yes. Tears, that's very significant. If they're not making tears, urine output. On an infant, we're going to look at the fontanelle. Mental status, if you're really dehydrated, you have lethargy. You just have no energy. That baby just kind of lays there instead of actively moving or crying. For the observation, we're looking at their abdomen. A toddler has a really pot belly. Infants as well have a round belly. But by the time they're preschool, they start to thin out. So being round and soft is normal, and we need to be able to separate just normal round from distended. Seeing veins is not normal, and we're going to look at, on that infant, the umbilicus. It shouldn't be red or have any drainage around it. We're going to listen to the bowel sounds. We might have hyperactive if they've got some kind of viral diarrhea going on, hypo or absent. And just like with adults, that absent, you wait a long time before you're willing to say there is nothing. But after abdominal surgery, there may be nothing for a while. Everything does shut down, and we're listening till those bowel sounds start to come back before we're not going to put anything into the gut until the gut is going to move it through. And then, right, we look, listen, and then feel. So the last thing we're doing is palpating. Is there tenderness? Is it firm? We do want to feel for the liver. You need the child laying flat, and you're going to reach under the right costal margin of the ribs. You should not feel the liver, or just barely as you reach under the ribs. So above where that right costal margin is, you may feel like you're bumping into something that's a little bit firmer, a little more solid than just pushing on over the intestines. That's the liver. As long as it's above the ribs, protected by the rib cage, that's normal. So we're measuring if it's distended. The spleen is on the other side. It's on the left, and it's a bit more lateral. So again, it should be up and under the ribs. You shouldn't be able to feel it. At Valley Children's, we don't necessarily feel for the spleen on every child unless it's been enlarged, but we are supposed to feel for that liver on every child. So common labs and diagnostic tests for abdominal problems. Ultrasound we use a lot. X-ray we use a lot. And just so you know, an abdominal X-ray is called a KUB. It actually stands for kidneys, ureter, and bladder, but it shows us the abdomen. We can do a barium swallow or a small bowel series, so we have them drink, or we put down an NG, something that's radiopaque, that barium, and we can see it moving through the intestines, and so it shows us if there's a place where it doesn't move through or it's much narrower than everywhere else. Blood work, we're looking usually things like amylase and lipase. For the pancreas, electrolytes, and then liver function tests are ALT, AST. For electrolytes, for me, if you're in my clinical, sodium, potassium chloride are our basic ones. Those are the ones we look at the most. Those are the ones that are the most numerous in your blood serum. And if those are off, then we start looking at other things. What other electrically charged item is in your blood? Often it's hydrogen ion, right? pH is the pressure of hydrogen ion. That's a cation. So if that's elevated, either your anion, which is chloride, and chloride's a follower. It goes or comes or goes based on everybody else. So if you add extra cation in hydrogen ion, your chloride will go up, or your other cations will go down. But they balance each other out, right? Your body's always seeking that homeostasis. We do have other electrically charged things, but most of the time, CO2, bicarb, which kind of give us an indication of pH without actually measuring the pH, those are usually the things that affect it. So those, for my clinical, that's what I want you to do. If you're thinking electrolytes, you're thinking sodium, potassium chloride. So esophageal manometry, that's measuring pressure. So they put a little tube down that measures how tight, how much pressure is there, and usually that's measuring sphincter pressure. A pH probe is also an NG tube put down that sits right above that lower esophageal sphincter, and it measures the pH. So it's measuring if you're reflexing up with the acidic stomach acids into the esophagus. With that, they usually do it for about 24 hours and keep a record. So mark down when they eat, and then when they look at the pH changes on that probe, is it happening after they eat? Is it happening an hour after they eat, when your stomach really should have already emptied? Okay. A scope, endoscopy, you can go into the stomach, right? Gastroscopy, you can go up the colon, colonoscopy. Hemocolt is looking for blood in the stool. When we send a stool sample for culture, sometimes they're looking for other non-normal, bacteria in there, right? You have your normal flora, the normal bacteria of the gut, but there are other things that shouldn't be in there, and very much the number should be extremely small. So they're looking for growth of those things, and the normal flora should stop that abnormal flora from growing. So they're looking at that. Sometimes they're also looking for is sugar or protein coming straight through without being digested and absorbed. Stool O and P, that's ovum and parasites, so that's looking for parasites, things like Giardia that you can get up camping. A hepatobiliary scan, we're looking at the liver and the bile ducts. Sometimes they need to see the actual liver tissue, so they'll do a liver biopsy, and then a lactose tolerance test. We can actually do anything, but lactose is the most common one. We have the person drink a liquid full of lactose, and then we measure their breath afterwards to see if they're digesting that normally, so their breath doesn't change, or is it sitting in the stomach, curdling, fermenting, whatever, depending on what we had them drink, and you're going to see a change in the gases of their exhaled air because that substance that we had them drink, again, usually it's lactose, but we can do it with lots of things. So that's how we diagnose that intolerance. They do not digest it, and that's usually because they're missing an enzyme. So when we do collect stool, a lot of our kids are in diapers, right? So we just take a tongue blade, scrape it off of the diaper, and put it into our little specimen cup, or use the swab depending on what medium it's being sent in. If you have liquid stool, you can't just scrape it off, so you may have to put a little piece of plastic, like just some plastic wrap down in the diaper to try and get a little puddle of that stool. If that doesn't work, we'll take a urine bag, but instead of putting it to catch urine, we'll apply it over the anus to catch stool. We do want stool without urine, because if we're searching for something, we want to know that it's in the stool. We don't want it's actually in the urine, but the two were mixed, so we couldn't tell. So if it's an older child, we're going to have them void first and then collect the stool. If it's liquid stool, we can put a hat down, just like you do for the urine, but turn it the other way and put it at the back of the toilet for it to catch stool. A child who can't get out of bed, who's bedbound, we're going to use a bedpan, but make sure it's clean. And again, we're trying to keep that stool not contaminated with urine. So on my exam, I do ask some questions about meds on GI. So remember, these are not that different from with adults. Histamine 2 blockers and protein pump inhibitors to either decrease the acid, so if you're refluxing, you don't keep burning the esophagus, or it producing less acid. Prokinetics make the stomach and the intestines move faster, so those kids who are having prolonged stomach emptying won't. We move the food out of the stomach so that it just isn't there to reflux. Antibacterials, antibiotics we use with caution, because you should have you should have bacteria in your gut, and even bacterial diarrhea, we often don't need to give antibiotic, but sometimes we do. Corticosteroids or other immunosuppressants, if you have something where there's a lot of inflammation, we're going to use that. Stimulants or laxatives to make you go if you're constipated. Antidiarrheals, again, used with caution in children. If there's something in the gut, we want to let it pass through. We don't want to hold it in there. Antiemetics to treat nausea and vomiting. Anticholinergics occasionally we'll use, and anti-inflammatories.